Hello, I'm pleased to welcome you to Social Prescribing, Current Practices and Community Conversations Conference. This is the first virtual social prescribing conference of its kind in Ontario and across Canada. Thank you so much for joining us. It is amazing to see so much interest in this work. We had what we thought was a very lofty goal of 100 people participating today. And last I checked, we had over 280 participants registered. So welcome. For those of you who don't know me, my name is Sarah Hobbs, and I'm the CEO at the Alliance for Healthier Communities. After working at a CHC for many years, I joined the Alliance in the fall of 2020, a few months into the pandemic and about 2 years after the Alliance launched its Made in Ontario approach to social prescribing. This was the first large-scale introduction of social prescribing in Canada. As it turns out, the arrival of social prescribing in Canada was extremely timely. The pandemic has had a huge impact on the mental health of people across Canada, and social prescribing is a powerful tool we can use to help address this impact. Let us start our day off in a good way with a land acknowledgement. We recognize that the work of the Alliance for Healthier Communities and Alliance members takes place across what is now called Ontario on traditional territories of the Indigenous people who have lived here since time immemorial and have deep connections to these lands. We further acknowledge that Ontario is covered by 46 treaties, agreements, and land purchases, as well as unceded territories. We are grateful for the opportunity to live, meet, and work on this territory. Ontario continues to be home to vibrant, diverse Indigenous communities who have distinct and specific histories and needs, as well as constitutionally protected and treaty rights. We honor this diversity and respect the knowledge, leadership, and governance frameworks within Indigenous communities. In recognition of this, we commit to building allyship relationships with First Nation, Inuit, and Métis peoples in order to enhance our knowledge and appreciation of the many histories and voices within Ontario. We also commit to sharing and upholding responsibilities to all who now live on these lands, the land itself, and the resources to make our lives possible. Please feel free to enter in the chat where you are located this morning and the land acknowledgement for your location. Over to you, Natasha.
Hello, my name is Natasha Baudin, and I am the lead on social prescribing for the Alliance. Until a few months ago, I was a longtime health promoter at Centertown Community Health Center. And I just wanted to talk a little bit about social prescribing briefly. So for me, social prescribing means connecting people with non-clinical programs and services that support their health and well-being. Social prescribing can be food, housing, arts, culture, movement, music, nature, and social connection. All the things that bring meaning to our human existence. We are pleased to be learning today from amazing people who will be asking great questions and speaking on topics as varied as social prescribing and climate change resistance, dancing with Parkinson's, and embedding social prescribing in the healthcare system. We are also going to be able to try out some social prescribing activities with our sessions, such as powwow workout, African movement, and others. And there will also be some coloring pages provided by the AGO and an Indigenous artist, Haoli Pichette, that people can color along with. We will provide those links. Pour ceux et celles qui sont ici, qui parlent français, je vais juste mentionner par la prescription sociale, on entend la mise en contact de personnes avec des programmes et des services non cliniques en vue de favoriser leur santé et leur bien-être. Une prescription sociale peut être en lien avec de la nourriture, le logement, les arts, la culture, l'activité physique, la musique, la nature ou l'établissement des liens sociaux. Toutes les choses qui apportent un sens à notre existence. Nous sommes heureux de poursuivre notre apprentissage aujourd'hui avec des gens formidables qui nous parleront de sujets variés, tels que la prescription sociale et la résistance au changement climatique, un programme de danse pour les personnes atteintes de la maladie de Parkinson et l'intégration de la prescription sociale au système de soins de santé. Nous allions aussi essayer des activités de prescription sociale, notamment une séance de danse powwow et une séance de mouvement africain. Nous avons aussi des pages de dessin fournies par le AGO et l'artiste autochtone qui s'appelle Haoli Pichette.
The Alliance is proud to be a leader in developing and delivering social prescribing through our team-based primary healthcare models, using a health equity lens to ensure the needs of people who face barriers are met.
L'Alliance est fière d'être un chef de file dans la création et la mise en œuvre de la prescription sociale par notre modèle de prestation de soins de santé primaire en équipe, en adoptant une perspective axée sur l'équité en santé, veiller à ce que les besoins des personnes qui font face à des obstacles soient satisfaits. Now, let's take a moment to find out a little more about who is in the room with us. So please take a moment to complete the poll telling us where you are zooming in from and your role. Je vais juste le répéter en français. Alors, prenons maintenant un instant pour en savoir plus sur vous qui vous êtes joint à nous. Veuillez répondre au sondage pour que nous sachions d'où vous vous joignez à nous et le rôle que vous occupez. So today I'm zooming in from beautiful Ottawa. I'm sure people are zooming in from many other places across Canada and actually across Ontario and even a few international attendees. So pleased to see such a wide variety of locations and roles, and great to have such a great group out this morning. Just waiting for our poll results to come in. Maybe this is a good place to give a great shout out to AV Canada, who is doing all of our tech support and have been absolutely fabulous. Okay, so we'll wait for the poll information to come back, and I'll just hand it back over to Sarah to introduce our plenary for this morning.
Great, wonderful, thank you. At the Alliance, we are pleased to have worked in collaboration to pave the way for social prescribing in Ontario with our RX community pilot on social prescribing in 2018. We have continued that work with a social prescribing project for older adults called Links to Wellbeing in partnership with the Older Adult Centres Association of Ontario. And we will be soon launching a new social prescribing project focused on mental health. In June of 2022, we started a Black-focused social prescribing project, which is taking the outcomes and learnings from the previous projects and adapting the work through an Afrocentric model of health and well-being lens. This builds on the work the Black Health Committee, made up of Alliance member leaders, had previously done through the development of a Black Health strategy. This project will help to put elements of that strategy into action. To inform and build on this momentum, we are pleased to present 3 incredible speakers in our upcoming plenary, Black Social Prescribing for Black Health. Please join me in attending this plenary session now, and I believe I'm turning it over to Daniel.
Hello, everyone. Good morning. My name is Daniel Chowden, and I'm a consultant with the Alliance for Healthier Communities working with the Black Health Committee. Thank you so much for joining us today. With me is Cheryl Prescott, and Cheryl is the ED for Black Creek Community Health Center, and Paul Bailey, who is the ED for the Black Health Alliance. I will be handing over to them momentarily, but we do have a short video. So I'll ask Cheryl to just make a short introduction of herself and then to turn over to the video. And then Paul, once you do speak, I'll ask you to also introduce yourself. Thank you. Cheryl?
Okay. Hello, everyone, and thank you so much for inviting me to participate in this important session. This is a session that is not only important to me and matters to me personally, but in the work that we do in our community at Black Creek Community Health Center, located in the northwest part of Toronto. I wanted to sort of describe what we do through this video that was produced. I think it was the last Black History Month celebration in February, that really demonstrates what we believe is social prescribing, utilizing a Black anti-racism, anti-Black racism lens. So on that note, I'll just let the video speak for itself and come back to you in a few moments with some commentary. So cue the video, please.
Jerusalema ikayalami ilondoloze uhambe nami zungangishilana Jerusalema ikayalami ilondoloze uhambe nami zungangishilana.
Hi, my name's Emmanuel.
Hi, my name's Ezekiel.
Hi, my name's Brandon.
Hi, my name's James, and today we're here on this beautiful Saturday afternoon helping out at Yorkgate Community Center.
Dawoyami ayikholana buso wami awukholana ilondoloze zuhambe nami dawoyami ayikholana buso wami awukholana ilondoloze dawo yami ayikholana buso wami awukholana ilondoloze zuhambe nami dawo yami ayikholana buso wami awukholana ilondoloze
Everyone, we got 2 minutes and
Jerusalema ikayalami ilondoloze uhambe nami zungangishilana dawo yami ayikholana buso wami awukholana ilondoloze
so much all for being here. We just want to welcome their entire community here at the Black Creek Community Health Center. Today we're celebrating Black History Month, and in the efforts to welcome our community, we're going to be doing some haircuts, hair braids, information on all health aspects, and also giving away some food, some gifts, and prizes to our community. Just one of the other things that we do as part of being here at Black Creek Community Health Center. I want to thank all the staff and everyone that's made this possible. To everyone that's part of my team, thank you, each and every one of you. And we're here, we're gonna have a wonderful afternoon with music, fun, enjoyment, and celebrating Black History Month.
Wow, thank you so much for that video, Cheryl. I really appreciate it. I really like seeing the kid, that shot with the kid was really wonderful. Paul, I'm gonna ask you just to introduce yourself, and then how this session will go is that I will be asking some set questions, and it really is a conversation that we're having between these two health leaders for us today, really focusing on the potential for social prescribing as a modality for improving health, but also for black population or other equity-seeking groups. So, Paul, just a quick, if you could quickly say a little bit about who you are and the organization that you represent.
I certainly can. Good morning, everybody, and thank you, Danielle. My name is Paul Bailey. I am a strategist, urban planner, and the executive director of the Black Health Alliance. The Black Health Alliance is a national charity that is working to improve the health and well-being of Black populations. And we do that by centering Black folks and defining the challenges and barriers to their health. We work with communities and health leaders like Cheryl to co-design solutions that respond to those challenges. And then we work to mobilize the tools, skills, and resources to build and sustain the interventions that hopefully over time will improve those health outcomes.
Thank you, Paul. Thank you, Paul. So a little bit about this project, the Black Social Prescribing Project that's been led by the Alliance. And first I want to give a big shout out to our donor, the Balsam Foundation, that really worked with us over time to bring this project to life. Black social prescribing itself is an approach to healthcare that can bridge the gap between social and clinical models of health. This specific Black social prescribing project seeks to develop a model for social prescribing that's grounded in Black and Afrocentric values and principles as an approach that focuses on improving the health and well-being for Black families and children across Ontario. And ultimately, what it's trying to do is to really reorient our health system towards populations that, or Black populations rather, that face historic and structural disadvantages based on anti-Black racism and other forms of discrimination. And I think my first question would be to both of the panelists, actually. What do you think a decolonized health system could look like? We use this word, but what does it mean if we were to imagine this coming to life, what exactly are we talking about? I'll start with you, Cheryl.
Okay, so thanks for the question. And I just wanted to have folks reflect on the video that you just saw. And for me, decolonizing the healthcare system means really looking and at our communities and showing the beauty of the Black community, for example. I have to speak to this because our system has not been built for diverse communities. It really was built on a white supremacy platform by and for folks that are not, that are white. So in the video, what I hope you saw was the partnerships that we have with our community, with the people that we serve, many of them Black. In the northwest part of Toronto, the predominant population is Black. So we are well situated to really do healthcare in a different way. We engage with partners that are representative of the community. We ensure that we have staff that are representative of our client population. And I hope that you saw the smiles on the faces, which to me is an indication of when things are done differently in a truly respectful way that's not a representative of the colonial system that we all are working and living in. The individuals have a sense of pride and a sense of ownership. So that engagement that we have with our community is so important to us. As you can see, in the Black community, it's about the family. You know, in that video, you saw children, you saw youth, you saw caregivers who were parents, grandparents, and just the community itself that takes care of itself. And for us, this is how we have to dismantle a system that really was not built for these kinds of communities. And we'll speak more about that.
Thank you, Cheryl. And I guess same question to you, Paul. And you know, you mentioned that you're a strategist, and I often think that strategy has very little to say about population-specific approaches that are for Black people. We're still trying to make that case. So I know if you want to just weave in your knowledge as a strategist with some of the things that Cheryl has mentioned, and what that would actually look like for a decolonized Afrocentric health system.
Yeah, I think the question around decolonization and Afrocentrics are pieces are large parts, but a couple of things come to mind for me. You know, oftentimes, so what I'm hearing Cheryl say is, you know, the way that people think about healthcare and healthcare is practiced and designed is in this very individualistic model where, you know, folks walk in, get some kind of clinical service and walk out, and it's kind of that, you know, conveyor belt kind of feel. And I think, you know, the first thing that comes to mind when I think about something that is more Afrocentric is something that embraces the community, embraces the family, as Cheryl said, embraces community leadership in again responding to the challenges and barriers that, you know, individual communities are facing. I think you know, some of the background is that Black communities face disproportionately poor health and well-being outcomes, right? So whether we're looking at the social determinants of health or whether we're looking at, you know, chronic disease, disproportionately poor outcomes. And I think you know, the other thing that comes to mind is the idea that we don't actually have a healthcare system. And there's a lot of folks that like to say we have a sick care system. So when I think about, you know, decolonization and Afrocentricity, I think about a holistic response that's about putting in the resources that are working to protect people's health and putting in the practices that work to protect people's health. So the last two things that come to mind is, you know, I think oftentimes we're in this kind of debate around how to deliver universal health care. And folks, you know, assume that, you know, if you have universal health care, you can go through a door and, you know, that means access. And I think, you know, it's critical that, you know, we don't think of access in that kind of transactional way. I think of, you know, community health centers that are part of the Alliance, et cetera, who take responsibility for the population in their catchment. They go out, they connect, they find the nooks and crannies, they set up, whether it's the hair braiding and the barbershops that create a different kind of avenue to engage folks. So, you know, I think, you know, when I think about decolonization, I think about responding to people's needs, you know, in those kinds of ways.
Great answers. And I want to pick up on some of the things that you've mentioned. Now, I'm thinking of the video, Cheryl, and what I loved about the video, which you and Paul have alluded to, is that I saw very little of what would be the traditional, what people might traditionally consider to be the delivery of health services. I didn't see a nurse with a stethoscope, for example. I saw people getting their hair braided. I saw families coming together. I did see that there was a vaccine clinic, but it seemed like an atmosphere that was not just come sit in a cubicle, you know, very clinical. It was a very different setting. And a big part of that, and what this project is, the social prescribing project is all about, is about advancing models of healthcare and well-being that are Afrocentric. And that's really something that has been piloted by Taibu. That's a part of one of the agencies that are leading this work. Now, I want to think about that. And I'm going to pose two questions. One is to Cheryl, who's a leader in our sector. How can other agencies, similar to Black Creek CHC, adopt a similar let's say, model of care, what do you want to call it, patient pathway, whatever it is, that looks like that? What are the tangible things that managers might need to consider, or implement when they go about, delivering services like that is akin to social prescribing. And then for Paul, that what we saw there is revolutionary. That is often about leaders like Cheryl doing something for the value of our that we know would work well for our communities. Similarly, for other centers, for all the centers that are involved in this project. What do we need to do at the policy level to have these kinds of models of health and well-being sort of systematized across the board? So it's not just a standalone thing, which is often a piecemeal approach to Black population health, but something that is sort of taken up by the province, whether it's the Ministry of Health or different agencies, or agencies like yourself that sort of broad oversight, and get these kinds of things instituted in health centers, but also other agencies beyond beyond CHCs. So two questions. One is for the policy side, and then one is the practical side for you, Cheryl, to tell leaders like yourself, like, this is what you need to do, and this is what it takes to do that kind of work.
Can you jump in first there, Cheryl?
Yeah, okay, go ahead, Paul.
Oh yeah, jump in first there, please.
Thought you said you were jumping. So, all right. So I think I can't answer this question by telling others what to do. I think what we do at Black Creek,
that's correct.
We listen to our community. We notice what is happening. We also, we collect data. We've been driving this message all through COVID around the importance of collecting race-based data and other kinds of data so that it will inform our practice. But in addition to that data, we have to ensure we have what it takes to interpret that data as well. We have to know the impact of historical trauma of racism on Black people. So I think the team that we assemble to address these issues in our community also needs to have those perspectives, and that comes with some training and an understanding and willingness to make that change, and to understand that, again, this system may not have been built for all of us. So in our case, we know what the population is around us that we serve. So we engage with our community members first. It's patient or client first. They tell us what their needs are. We engage with the partners that are culturally representative of the population that we serve. So in that video, we worked with an organization called Brothers and Sisters Keeper, which started out as a basketball program, small grassroots organization, but really is grounded in the community and knows the issues. So for example, when we hear that young girls and boys are showing up at the basketball practice, with feeling maybe not so great about themselves because of the way their hair looks, or because they, perhaps it's an income and economic issue. We listen and we try to figure out what needs to be done. So the hair braiding in this case is one of those things, but it is only one. And I think it makes a big difference to the individual. Now, as a larger, broader community, we also work with businesses and Black businesses within the community, young people who may have talents and skills, and they're the ones we engage with even to provide the services and help build their capacity to be entrepreneurs, to break the cycle of poverty. So it's an overall package, I think, that we put together to ensure that, we are serving the community the way they need to be served. And this is the same for any other community that is sort of disengaged or who have barriers to access, such as Francophones in our province who may not have language-specific programs, or the Indigenous population, LGBTQ community, or any community. We need to know, we need to listen, and we need to learn and be willing to pivot our services to the needs of the community. And as you said, Daniel, you said you didn't see a stethoscope in that video. There was a stethoscope because what we were doing was we were screening people for high blood pressure, because we know the statistics tell us that we have a high prevalence of people with high blood pressure in the Black community. So, they come in for maybe a haircut or to bring their child for a haircut, but There's some Black doctors in partnership with the Black Physicians Association of Ontario to, do their blood pressure checks. And we've seen examples where people have not had access to primary care, but through this mechanism, they come through our doors and it's, what do you need? You need food, you need a haircut. Can we test your blood pressure? Do you have a vaccine? So it's just doing healthcare in a very person-centric way, I think, which I believe is effective. So now,
Thank
Paul,
you.
I'll turn to you.
Yeah, and it's to Paul with the big policy question. Sorry, Paul, I think you're muted.
Whoops, sorry about that. I said it was a very big question, Daniel, but a couple of things came to mind. I think what the video shows to me, the video that Cheryl showed, is that trust is a key social determinant of health. The work that organizations like Black Creek and other CHCs are doing in responding directly to specific communities' needs, like Black communities, I think are profound. The evidence kind of is in front of your face. And so the first policy thing that comes to mind is, we realize that it's important not just to push for, universal health care or social prescribing as a whole, but we have to, given what we know about the conditions, the stats and the data, we have to push for distinction-based policies, strategies that are focused on improving the health of Black communities very, very specifically, because it sometimes requires a different approach. I think oftentimes about, like, again, in this social prescribing kind of lens, one of the key pillars here is that you're connecting and referring people to the service, whether it's in your own organization or whether it's, partners on the ground. But, when I look at the landscape, even here where I am in Toronto, but other parts of the province, particularly in the north, for culturally responsive services that work to support Black communities, there are huge challenges with those services. And in some communities there are none. And so I think when it comes to the policy solution there, it's about investing in the organizations that have the trust and the expertise to serve their communities. And then I have two others. In the context of talking about the social determinants of health, it's interesting. Because we're here to talking about, social prescribing, and, often that's kind of, again, the direct referral, but the vastness of the challenge that we're facing, in terms of food insecurity or core housing need, or, low income, concentrated in particular geographies across the province, et cetera. These are big, massive issues. And so I think in addition to, pushing for the movement around social prescribing, in order to make social prescribing work for Black communities, we also have to be having another conversation concurrently about how we're driving the policy solutions at that end, that where we can resolve, some of the issues around income, that help to resolve some of the issues around food security and housing, et cetera. And the last thing is, and I think we're moving in Ontario in this direction to a certain extent, integrated care. We're working in Peel right now with some local community organizations to push forward an integrated primary care and social services of the kind of healthcare space that is designed specifically, again, to serve Black communities, designed to not just serve those who are going to go through the door, but to go out and outreach and connect, leverage the models, again, learning from whether it's Taibu or, Black Creek, et cetera. And so I think the more that we can advance that conversation around integrated care and support and resource those things effectively to serve the population, I think the better off we'll be, in driving forward this piece around social prescribing.
Thank you, Paul. So I think something you mentioned, Paul, made me think about the challenges to doing this work. It is still pretty difficult to work and advance in Black people. It's still an inherently political process, and we often find that we have to make the case despite all the evidence being right there in front of you. So and it's a question to both of you is, how do we deal with pushback to these kinds of programming? And maybe even, part of it, and give a bit of an answer, but I think this programming benefits everybody. You know, that's the first thing. You go into a community and you're working on a specific issue, you know, whether it's screening for high blood pressure, it's not specifically only for Black people. Other people can also benefit from this kind of specific programming. But other people definitely push back, and that has and that can, you know, really negatively impact or long-term stymie our efforts in the long term. So how do we deal with opposition? Because that still is part of the challenge that we have in bringing these kinds of programs to scale. So for both of you, Paul and Cheryl, or Paul, whoever wants to go first.
I'll jump in. I have difficulty answering this question sometimes because, you know, the backdrop is, I think many of us might imagine that there is somebody that has, you know, a good eye on the system, is looking at health disparities and deciding where they're going to put money in. And the reality is, like, from my experience, that's not the case. It's chaos, and it's folks. It's about relationships. It's about power, and it's about who has the power to grab the resources that are going to help themselves and their communities first. And so I think part of the conversation here is about power. It's about recognizing that power, and it's about making sure that, you know, we're pushing for a different system where we're at the table in a different kind of way. I think the second thing that comes to mind is something Cheryl said earlier: collection of socio-demographic data, race-based data, race and ethnicity-based data, other socio-demographic data, I think is critical to the conversation. We saw during the pandemic, again, when folks like Cheryl, Angela Robertson, other CHC leaders were strong voices in pushing for the collection of socio-demographic data to look at what was happening around the COVID-19 pandemic. That unlocked a whole bunch of understanding for those of us who were, whether we were in the space of advocacy or whether in the space of service provision, to try and target and understand kind of where things were happening. And so I think continuing to push for that socio-demographic data is critical for the work. The part that challenges me sometimes is, again, you know, as an organization, our role isn't to deliver services. It's really about how do we work with communities to improve health outcomes and doing whatever that takes. And so often that does take the form of advocacy. And so I think it's important for us to hold systems accountable to their responsibility. But I sometimes feel like you can spend 20 years banging your head against the wall, trying to hold folks accountable. So I'm not saying that we shouldn't hold folks accountable, but I think taking the steps that, again, many CHCs take of listening to your community, combining that with some data, and starting, and where we work together to kind of build the tools and solutions that are responding to, you know, our own health needs. I think for me, that's the approach that I think, you know, at the Black Health Alliance we're leaning into. You know, how are we working with foundations or organizations? How are we pulling together the partnerships that allow us to build and work? You know, that said, you know, again, I think, you know, the question was about pushback, and I kind of went all over the place, but I think, you know, it connects to the conversation that we're just having around policy. It's important to push on those policy pieces, but I think, you know, the moment we put our health in other folks' hands, it's like that's a losing strategy. And so I think, you know, learning and supporting the work that many folks are doing already is where I lean into.
Carol?
Okay. All right. So Paul, perfect segue, putting our health in our hands. We now at Black Creek are from a vaccine strategy. We now have a wellness clinic called Your Health in Your Hands, because we truly believe that that is what is needed. So, but to answer the question around what do we need to do, I believe we're in a courageous space here, and I'm going to be brave and say something that may not be popular. So the continued poor health outcomes that we see amongst racialized populations, amongst Black, Indigenous, people of color, it leads me to two conclusions. One is that we believe that Black people, let's speak about Black people, are inherently inferior and destined for poor health. The other belief is that the system is designed in a way that perpetuates those poor health outcomes for our community. So there's so much stats, so much that especially that came out through the COVID pandemic that points to this, the higher rates of people infected with COVID, higher rates of death, mortality amongst the Black population, high rates of diabetes and mortality from diabetes, higher rates of infant mortality, homicides by gun violence, so much more points to the fact that this system might be designed this way. So if we believe that it's the latter, then we should all be outraged right now. We should be mad. We, you know, I won't swear, but we should be doing more to fix it, because I don't believe that we are inherently inferior. So that can't be it. So there must be something within our system that is making this continuously happen. So, or is it that we're just immobilized by the maybe the fact that we don't know what to do. The solutions are just not as obvious as some of us may see it. So I do think we need system change. We need to topple a system. As Paul said, there is no system, but we have to figure this out, because otherwise we will continue to perpetuate these poor health outcomes amongst certain communities, such as the Black community. I mean, the power of structural racism is large. It's immense, but we cannot. If we want to really make a change, we need to, in my opinion, move our outrage to action. And it cannot just be by those groups that are impacted. For example, Paul mentioned it takes leadership, strong leadership, and I believe that. However, those of us that are in this work are also subject to the same racism, anti-Black racism. So we do need to do something that is, you know, out of the box, and we need to do it quickly. And the CHCs have been doing it for decades. We utilize a population-based approach. We utilize a team-based approach that's integrated and is what is really, really needed. And I'll use the example, Daniel, I'm sure you have another question about this, but you know, I see it every day. I see, for example, with some of our patients that are, you know, dealing with diabetes, they're given a prescription for drugs that are high price that they cannot afford. They rip up their prescription before they leave the office. What will it take if, as a system, we work with our clinicians better? We really embed the team-based approach to care, so that someone can then reach out to that client and find out what they really need. And really, you know, how do we help them with their, whether it's income or just figuring out how we can help them get the right food or into an exercise program or whatnot, to ensure that they're taking care of their condition while they cannot, for example, get all the medications or afford the medications they need. And that is what social prescribing is. It's around working together in a team-based way, addressing a population in a targeted way. We cannot be colorblind in this work. We have to address the issues as they are, and we have to acknowledge what's happening within our system and what's happened for not just decades, but centuries.
Cheryl, I could listen to you for the whole day. So I just want to say that's a great answer. I appreciate what you and Paul have said. And you know what I teased out from both your responses is, you know, there are things that you can't, there's of course going to be pushback, but there are tools that we have, and we have to wield them, you know, in a sense. Socio-demographic data, and it paints the picture in clear numbers for people to see. And also, if we believe certain things about ourselves and the role that we have, not just in the health system, but in Canadian society, then some of that could either, you know, demotivate us or empower us. And if it empowers us, then it is our citizen right to ask for a health system that fully understands and incorporates us as the people who we are, living in Canada and in Ontario, and as users of the health system that should work for us. I have two questions, and And just for everyone, we're ending in about 15 minutes. I don't know how many questions we can get through. The first question was, are there any thoughts on social prescribing for Black African Caribbean seniors living in isolated and remote areas? I'm not sure that's, I mean, both of you can answer that, but we do have a seniors. It's interesting that you mentioned seniors. There's another part of this project that really works with seniors, but just today we're really only speaking about the Black social prescribing. So here at the Alliance, we do recognize that seniors is also one of those groups that are very important and have unique sets of needs, and also might have benefit from social prescribing programs. But I put back to the question, any thoughts you have on how you can go about developing those kinds of programs? And now thinking about races as well within it. Or Paul, go ahead.
Jump in with a few quick thoughts. I think, the way I think about this is it's important to understand the population. So, again, trust is a key social determinant of health. And so I think it's important that you open yourself up to engaging with communities and listening and understanding, about those needs. I think it's also important to build those partnerships through that engagement with the community, because it's really those folks that are going to enable the connections and the heart, if you will, to the initiatives that folks will do and kind of bring that community leadership to the work. I think when it comes to the piece around isolation, etc., we're having more and more conversations with communities in the North. And it's a challenge because there is no sometimes neat solution. Sometimes there isn't broadband access in the same way that we might have in the South, but sometimes there is. And so I think, again, working with communities, understanding some of those needs, understanding that, there may be opportunities for novel partnerships where we leverage, virtual environments to connect folks who, otherwise, feel disconnected from, people and culture, etc. But I think the centerpiece of what I'm trying to say there is that it's driven through understanding who your population is and reaching out and through building a platform for those folks to empower themselves in that. And I think the solutions naturally come.
And the only thing I could add to that, Paul, is that, for seniors, one common thread amongst seniors, and I believe all seniors, is something like loneliness. I mean, loneliness can kill. And there is lots in the literature around ensuring that we do not leave people alone and that we find some sort of connectivity, whether it's in person. And I know that the pandemic has challenged us all, but what can we do as a system to ensure that people have the tools? Well, how could we advocate for ensuring that everyone has, whether it's a device or the knowledge to use those devices to connect with each other? Our population that we serve is largely newcomers to Canada, or they're from somewhere else. Many are separated from their families. So they are, whether they're seniors or not, they're here alone and they're facing such isolation themselves, lack of connectivity to people and to care. And so I do believe that many clinicians are probably challenged by this, because what we find is that some of our seniors make a clinical appointment simply because they want someone to talk to. So is that the best way to really utilize our healthcare system? Or is it developing more social programs in our communities, making phone calls to the seniors just to have a chat? Our community health workers told us at the beginning of pandemic, when they did call our seniors, they just kept them on the phone for about an hour talking because no one else checked in on them. So I think there's some very low hanging fruits that things that we can do that are cost effective and could really save lives in that population, whether remote or urban.
Yeah, no, I completely agree with both points. Recently, I was doing in some of the work I've been doing. I did a focus group, and it involves seniors, and a lot of them said, "We're just looking forward to interacting with someone today." We understand we can't always show up at the health center, but kind of want to do that. And I think, that's such an important determinant of your health. If you look forward to interacting with someone and having human connection, and it is a big deal. We have another question, and I believe this question is from Rebecca. Do you have any strategies or you've used or suggestions for encouraging medical practitioners who might not be as involved in their communities to expand/reframe their thinking to support integrated care? And I'm guessing here, Paul, we can go with Paul and then Cheryl. You could draw from this work that you're doing in Mississauga, or Peel, sorry, with your integrated care work. I'm not sure if there's anything you can talk specifically related to this question. And then for Cheryl, I think you understand well this question as well. You could draw from some of the experiences that you've had working alongside doctors and making this case.
Yeah, I definitely think this question is probably more in Cheryl's wheelhouse. But what I'll say is, again, thinking from like a policy perspective, I think the assumption is that there aren't systemic disincentives, if you will, that exist as barriers to like integrated care, right? So most healthcare or primary healthcare is delivered in a sole practitioner function. And I think, often sometimes the CHC model, the integrated care model, sometimes may pose a threat to those who built their lives and their practices in this function. And I think that's changing with the, new grads coming from med school. A lot more are saying they want to work in team-based and integrated care fashions. But I think from a policy perspective, you have to make a decision and push and enable the design of the system to kind of embrace that integrated care, right? At the center of it is dollars and cents. And I think until we deal with that challenge just around how dollars incentivize, individual practice sometimes in opposition to team-based care. And it's not a knock against doctors, just the way the systems function. I think, it's hard to push that piece forward, but I'll throw it over to you, Cheryl.
Absolutely. There's no incentive. There is no incentive to do things differently. How can a physician or clinician, whether it's a nurse practitioner, a physician, seeing a client for 5 minutes, 10 minutes, really understand what's going on in their lives, the impact of race and racism on their lives? They're dealing with the biology, the genetics, the clinical presentation. So again, in CHCs, I would say we don't have this problem because our physicians and our care providers they spend time with their clients. They're there to listen, and they have a team around them to pass on an issue. For example, if they identify food insecurity, and we ask that question, that's part of the work we do. We ask the question is, can you afford to buy this food on a daily, weekly, monthly basis? And if not, they refer them to one of our community health workers or a dietitian or a navigator, so that there is that care. But our model is just not unique, and our model takes a lot of hit because maybe we don't see as many people as we should, but we see people and we identify what matters to people. We're not just looking at the blood pressure or the blood sugar level. We're looking at their life as a whole. So I think within the system there's not that incentive. Many solo practitioners in our communities are challenged by the fact that they don't know what's going on in the community. They work in the community, but what would it look like if all of them were equipped with a team of providers, community providers and others that could really support those clients? If we truly believe in community centered and client-centered care, we would invest better.
Mm-hmm. It's true. That's absolutely true. So we have just 5 minutes left, and I don't think we have any, that's enough time to take another question, but I would love to leave, to end this panel with some last words from both of you. Anything that you want to say more generally about what the potential that social prescribing holds for Black populations, and then perhaps for a better health system. I know you started on some of this, but I do believe I'm an eternally hopeful person. And I think some of the things that you brought out today really bring some of that to life. I think social prescribing is one of those game changers for us. And I'm just wondering if you have any last concluding thoughts about what that can actually look like. And perhaps if you do, then to share a bit about what your vision is, if done well.
I'll jump in really quickly. I think for me, social prescribing, Cheryl ended off by saying they screen for the social determinants of health. They're interested in not a sick care system, but a healthcare system. And so for me, that's what social prescribing represents, is the opportunity to build a holistic healthcare system that's responding to the whole needs of the person. That said, I think when we're speaking about the needs of Black communities, we can't ignore the context in which we exist. And so, concurrently, as I was saying earlier, it requires us to really think carefully about the policy, the community leadership, the other strategy is the investment in services to refer people to. It requires us to think about the other strategies that work collectively with social prescribing to address these vast health inequities. My vision for a healthcare system is, again, one that is prioritizing those key needs, those key levers: housing, early childhood development, food security, income security, and one that can respond to those emergent needs, and one that we don't have the system that currently exists where Stats Can just recently released a report in August that showed that Black folks across Canada had the highest age standardized mortality, 49 for 100,000. I want a healthcare system that realizes that this is a situation that's going on for us and is equipped to respond and prevent that from happening in the future. So yeah, I'll leave it there. Thank you.
Thank you, Paul. Cheryl?
Hard to sum it up, but I think I want to repeat what something around, if we truly do not believe that Black people and other equity deserving groups are inferior in our society, we need to do better, and we need to work together in this and not leave it up to, for example, only the Black leaders. That's one. It's so important but as a Black leader, I often sit in uncomfortable spaces because I do want to see that change. And I think the Black Social Prescribing Initiative is an amazing movement in that direction, because we cannot address social determinants of health without addressing racism, and in particular, anti-Black racism. So I see this as a way to really reimagine the types of social and healthcare changes, and one that cultivates healing and not harm, and really will lead to racial health equity. I'll end there.
Thank you so much. And many thanks to you, Cheryl, and for you, Paul, for joining us today on our first plenary, our opening plenary. This is a very, very insightful conversation. I hope, for me, I'm leaving very energized, but I really hope for those of you who have not heard these speakers before and are also concerned about Black social prescribing, that we have left you with something that you can take back to your organizations to further this work. This project is going on for another 2 years, the 2.5-year initiative. But the case is has been laid out clearly today. And we do hope that, some of you will take up this work with us, and so that we can continue to scale these kinds of important game-changing initiatives that will really meet the needs for Black population, Black communities in Ontario. Thank you so much for your attention. I'm now going to pass back to Natasha, who will share with us the poll results. And then after that, I believe we have a short break. Natasha, over to you.
Thank you so much, Daniel, Cheryl, and Paul. That was an amazing presentation. I also feel very energized and great way to start our day. I believe we're going to try to post the polls that we tried earlier right now. So that technical magic happens by our amazing technology support. Hi, everyone. I'm looking at the results. So we have 1.3% of people joining us from Alberta. No one from the Maritimes yet. They might come later. From the Atlantic provinces, we have 5.3% of our folks are from British Columbia, beautiful British Columbia. 1.3% people joining us from Manitoba. Oh, a whopping 88.2% from Ontario. No people from Quebec yet, but maybe later. Oh, we have people joining us from the north. Excellent. And we have 2.6% of people are joining from outside of Canada. Welcome, everyone. And then looking at our sectors, so 1/3 roughly from community organizations, more than 40% from healthcare, a good 4% from research, academia, and students, 2.6% from governments and policy makers, and then 18.4% from others. So we'll chew on those mysterious others and let our imagination run wild. And then our next sessions coming up, we have two fantastic, amazing concurrent sessions coming up. Building resilience, climate and equity context of social prescribing, and social prescribing leveraging the power of students. So hope to see you in our upcoming concurrent sessions.